It's a pleasure to have everybody here. It's also my pleasure to introduce Dr. Erin Dunn, who is a social and psychiatric epidemiologist with expertise in child adversity, genetics, and epigenetics. Her research laboratory uses interdisciplinary approaches to better understand the social and biological factors that influence etiology of depression among women, children, and adolescents. That's one side of it. She's an associate professor of psychiatry at Harvard Medical School, an assistant investigator at Mass General. Her most recent work focuses on identification of sensitive periods in development, including through studies that investigate adversity effects, again, back to that same topic, on DNA methylation and the role of deciduous teeth as novel biomarkers. And I love the use of deciduous, which for teeth and trees have as a joint use. And she is a self-proclaimed science tooth fairy. And after talking with her a little bit today, I realized that her work she works a lot with epidemiologists, of course, and public health people, but also biologists, dentists, as well as anthropologists and archaeologists, among many others. So really want to welcome Dr. Dunn, and we're looking forward to hearing your talk. Thank you.
Thank you so much. All right, let me actually. All right. Away we go, fingers crossed, hoping the technology works. So, okay, I'm going to ignore all of these admitting, assuming someone else is going to do that. Okay, great. So I'm Erin Dunn. I feel like I'm winging it on the technology front, but I'm really excited to be here today and share with you more about the work that my team is doing around childhood adversity. I'm going to talk with you about the work we're doing in the space of mental health and some opportunities, I think, to reduce risk and promote resilience across the life course. I have no disclosures. So let me start by sharing a little bit more about what we know in terms of childhood adversity, which is an important starting point because childhood adversity is a common and highly impactful social determinant of mental health. So on this slide, you can see I'm presenting a number of different kinds of adversities. Some of these adversities are common, some are more acutely occurring, some happen to kids inside their household, some happen outside. Some are perpetrated by people, some are more natural. But what we know from large-scale epidemiological studies is that more than half of all youth growing up in the world today experience at least one of these kinds of adversities. We know that racial and ethnic minority children are disproportionately affected by certain adversities, as are female children, including things like sexual and violence and assault. And what the latest data are suggesting is that adversity is estimated to about double the risk of a mental disorder throughout the lifespan. So it may not surprise you to hear that childhood adversity is associated with an increased risk of a psychiatric disorder that onsets in childhood and adolescence. But we also know that psychiatric disorders that onset for the first time, even in adulthood, can also be traced to childhood adversity. And I think one of the statistics that's also emerged from large population-based studies, which I think is both simultaneously really sobering, but also gives us optimism for opportunities for intervention, is that if the effects of adversity were causal, they'd explain about 30% of the total population burden of all mental disorders. So the idea of mental disorders being a large pie, childhood adversity explaining upwards of 30% of that pie. The story doesn't end, though, with mental disorders. We also know that multiple adverse physical health outcomes also result from childhood adversity exposure. And these are results that were published in a systematic review and meta-analysis, very large sample size. And what you can see here is increased risk of both physical and mental health outcomes, so cancer, cardiovascular disease, respiratory disease, and so on. And I think in one of the most poignant parts that they made note of in the discussion section of this paper was to say the outcomes most strongly associated with multiple adverse childhood experiences, or ACEs, represent ACE risks for the next generation. for example, violence, mental illness, and substance use. I also want to call out, particularly because I have an interest in this interface between mental and dental, so to speak, that these poor physical health outcomes also include oral health problems. Folks within my group did a systematic review where we looked at the relationship between childhood adversity and a number of different oral health markers, including decayed, missing, or filled teeth, dental attendance and utilization, and ratings of oral health. There were a lot of papers that we identified, only a handful, 28, met our inclusion criteria. And what we ended up doing was grouping the papers just based on the direction and magnitude of association. And what we found was that largely most papers were reporting at least one association, a positive association between adverse childhood experience, exposure, and an oral health outcome. And we saw in general about a doubling of the odds of at least one poor oral health outcome for being exposed to just one particular type of adversity. So hopefully this kind of data is building an argument that's starting to convince you about the importance of childhood adversity. I've always studied childhood adversity in the context of depression, which is another major public health issue and something I've been interested in since I was an undergrad. So to make sure that we're all on the same page, let me just share a little bit about the epidemiology of depression. So it's a disorder that's common throughout the lifespan. About 1 out of every 5 people will experience an episode of depression at some point in their life. We also know that it's a disorder that disproportionately affects women. So during childhood, boys and girls experience similar levels of depression, but something happens at adolescence where girls start to outnumber boys by a ratio of 2 to 1, and that disparity persists throughout the lifespan. We also know that depression is associated with a host of negative consequences in the short and long term. People miss out on educational and work-related opportunities. They have challenges in terms of social relationships, side effects from medications, and comorbidities in terms of substance use and the like. And I think in its most severe form, suicide and self-harm. So because depression is so common and because it disproportionately affects large segments of the population and is associated with so many negative consequences, it's maybe not a surprise to learn that depression is currently the second leading cause of disability worldwide. So in my group, we're really focused on trying to identify opportunities to prevent depression, which we think is really critical because it's a disorder that strikes when people are young, and once it emerges, it's highly recurrent. So we know from some epidemiological data that about 20 to 40% of people with major depressive disorder will have had their first onset by age 18. Keep that statistic in the back of your mind because I'm going to come back to it later on towards the end of my talk. And we also know that about 3 out of every 4 people who experience depression will have a relapse at some point in their lives. So to me, when I hear data like this, or when I see data like this, it really moves me forward to say, we've got to better understand what causes depression so that we can better intervene and do that as early on in the lifespan as we possibly can. So my group has been focused in those specific areas. My work is at this intersection of the who, how, and the when around depression prevention. So we do work looking at who is at risk for depression using genetic and other markers of vulnerability. We do work to try to understand more of the mechanisms. How is it that childhood adversity gets into people's bodies and shapes their risk for long-term health? We also do work on sensitive periods, or this idea of there being developmental time periods or life stages when experiences like adversity differentially matter. And then the last area is where we're also doing work to try to build novel infrastructure for scientific knowledge translation. So the idea here is we're not just interested in publishing papers and sort of speaking to other scientists. We really want this work to get out there and try to make a difference in the lives of communities and families. And so one of the areas where we're doing that now is we started a birth cohort at Mass General called Brain Health Begins Before Birth, and where we're trying to marry not just observation, but also active intervention in order to be able to identify opportunities for intervention for brain health related conditions. So what I want to do in this talk is summarize 2 specific aspects of my lab's work related to childhood adversity. The first is around the concept of identifying sensitive periods in development. And then the second is in terms of overcoming current challenges that exist in measuring childhood adversity exposure and how I think baby teeth might be able to help. I'll then talk a little bit about, towards the end of my talk, about the clinical applications and implications of this work. And really the bigger goal is I just help to build some enthusiasm and curiosity among scientists and clinicians who are interested in the brain and other organs, including folks in dentistry, to work together, because I think there could be some really important discoveries we can make about brain and body health when we work together. So before I move on, I just want to get a little bit of clarity, because some of you I'm thinking might be wondering, do all these terms mean the same thing? You've heard about ACEs, you've heard of childhood adversity, are we talking about the same thing? So I tend to use the language of childhood adversity because I see it as more all-encompassing. And the idea here is that these are just events that deviate from children's typical experiences. Now, we can argue about the fact of, adversities being so common. Maybe that's not the best definition, but I tend to like to use that as this more all-encompassing term. Childhood adversity is differentiated from stress, meaning the actual experience of an external event or the stressor. Trauma are those stressors that reach a level of significance that are really profound, where people are worried about their physical or psychological well-being, and where there's situations that could involve actual perceived death. Toxic stress is language that was coined by the Harvard Center on the Developing Child and really tries to differentiate those experiences that happen to kids without the context or without the love and support of a caregiving adult. And adverse childhood experiences, or ACEs, are really the term that's been coined by the Folletti and Anda studies. And those focus really narrowly on a set of 10 childhood adversities. So hopefully this just gives you a better sense of the language that I use and why I use it, and might be informative. So let's dive in and talk a little bit about sensitive periods in development. So if you turn to the literature, you will see that there's a lot that's been published around, timing and how you can conceptualize timing. And we've always been interested in this around how childhood adversity might shape risk for poor health outcomes and how we think about timing in that context. So within the literature, there's been a number of different theoretical models, that life course epidemiologists and others have discussed. One is a basic exposure model, and this is a model that simply focuses on whether or not people are exposed to adversity, for example, positing that people who have these adverse childhood experiences, have an increased risk of an adverse health outcome relative to people who've never been exposed. There are also accumulation models, and these are models that focus on some aspect of the amount or duration of exposure. So here I'm showing a really basic dose-response relationship between the number of adversities exposed, or the time periods of exposure, and the risk of health outcome. You can imagine that there's different functional forms for this, where it might be nonlinear, but just as an example. There's also recency models, and these are models that talk about the time since the onset of exposure. The idea being that people have the greatest risk shortly after they've been exposed, and then that risk decreases over time. And then finally, there are these sensitive period models, and these focus on the age at exposure to adversity, positing that maybe there are developmental time periods of increased sensitivity to life experiences. And so within my group, we've been trying to better understand, which one or more of these theoretical models might be driving risk for depression, because we think it's going to have important implications for how we intervene. So if the data we find are consistent with an exposure model, then our goal as public health practitioners is to try to identify people who've been exposed. And we can do that at any point in time. If the data are more consistent with an accumulation model, that suggests that we want to intervene early before people are accruing these multiple adverse experiences. If the data are consistent with a recency model, that suggests we want to intervene quickly, but maybe it also suggests doing nothing is okay because people's symptoms or their risk will decrease over time. And if it's a sensitive period model, it suggests that we want to intervene shortly before or during those peak periods of increased sensitivity. And this is where I think of the sensitive periods as being both high risk periods or windows of vulnerability, but also high reward periods or periods of opportunity when enriching interventions and positive life experiences might also be differentially important. So what our goal has been is, to try to generate the research evidence that will enable us as scientists to help make more precise recommendations for clinicians and policymakers about when to intervene, and do that on a high resolution timescale. In other words, let's get more granular than just saying early, or something like the first 1,000 days. That's a little bit more, in my opinion, kind of policy driven. So let me walk you back and tell you about the very first study that we did in the space of sensitive periods. This was using data from AdHealth, large population-based sample in the US where kids were first sampled in middle school and early high school. And in this data set, they had asked kids at I think it was the third time period of data collection, to retrospectively report whether they had ever been exposed to either physical abuse or sexual abuse. And if so, how old were they at the age of their first exposure? There's lots of problems with self-report data here and retrospective measures, and I'm going to come back to that. But in the meantime, what we did at the time was to use this data and code people based on the timing of their exposure. And what we modeled was the timing of exposure compared to unexposed, as well as the timing of exposure comparing groups to each other. And so what you can see here is that generally across the board, kids who were exposed to physical abuse, regardless of when, had an increased risk of high depressive symptoms compared to kids who were never exposed. But then when we compared the timing differences, we saw that this preschool period, or time from 3 to 5, had an increased risk relative to kids who reported being first exposed as adolescents. And similarly, for sexual abuse, we generally across the board found these increased risks based on being exposed. And similarly, we continue to see an increased risk of preschool relative to a prepubertal period of 9 to 10, as well as an increased association in the school age, kind of 6 to 8. And over the years, we've searched for sensitive periods, hoping to learn the level where they might operate. So a lot of this work began in my group understanding, childhood adversity as it relates to depression. And then we've gone on to look more at these intermediate phenotypes, the idea of these markers that might be more potentially proximal to the time of exposure and maybe the level where sensitive periods are more readily detectable. And so over the years, we've looked at a number of different intermediate phenotypes, how people cope with stress, insomnia, executive functioning, and really where we've been focusing mostly is now on molecular targets. We've also been doing work to develop and apply better analytic tools to analyze longitudinal data where you have these repeated measures. And so this is a collaboration I've had for almost 10 years with Andrew Smith from the University of the West of England. And he really pioneered this approach called the structured life course modeling approach, which we refer to as the SLCMA. I think it's a great approach because, bless you, it allows you to work well with repeated and often correlated measures, which you oftentimes have in longitudinal data sets. But what I think is really nice about it is that it balances exploration and confirmation. So you start by saying, how do I think these relationships exist? What do I think is the relationship here? And so you start to identify at the outset of your analysis pre-specified theoretical models that describe the relationship between your exposure and health outcome. And then you work through the SLCMA to ultimately identify the fewest combination of variables that explain the most amount of outcome variation. So you run the SLCMA in stages. So as I said, you start by encoding one or more of your variables into these pre-specified models. So oftentimes when we're running models, we're looking typically at accumulation, recency, and sensitive period models. We've also looked at mobility models where people are exposed, unexposed, exposed again, and things of this sort. One of the ways that you can visualize the data is by, after you enter it into a least angle regression and use lasso as your estimation procedure, you can then use these elbow plots. So in an elbow plot, you have the number of encoded variables on your x-axis, and on your y is your r² percent variance explained. And so at every step of the model, you can see which theoretical model is explaining the most amount of outcome variation. And you get any kind of gain by adding in additional theoretical models. So in this example, you can see that it's not just accumulation, but it's accumulation plus exposure during this third time period, that the combination of those things is explaining the most amount of outcome variation. Elbow plots get really hard to look at when you're doing high dimensional analyses. So that's where you can also use covariance testing and selective inference to also look at whether statistically, whether you're getting an increase in r² explained for every step in the model. And so we've used SLCMA and other approaches over the years to look at, a range of different outcomes. And what I want to turn now is to tell you more about work we've been doing in the space of DNA methylation, which is a type of epigenetic modification that is thought to not change the sequence of your DNA, but change how your genes are functioning. And so we have been doing work in the Avon longitudinal study of parents and children, which is a birth cohort out of Bristol, England. And in that cohort, they collected repeated blood samples for epigenotyping at birth, age 7, and age 15. And Alex Lussier, who was a postdoc in my group and has recently transitioned to faculty, did some work to look at how the timing of exposure to adversity, and adversity being coded as things that were more proximal to kids, things like physical and emotional abuse, all the way up to markers of neighborhood disadvantage. And we use that data to look at DNA methylation at about 500,000 loci across the epigenome. And then using the SLCMA, we said, what theoretical model best explains variation in CPG level or DNA methylation differences across the epigenome? And so here are the results. So this is a Manhattan plot. And in a Manhattan plot, you've got chromosome on your x-axis and the negative log of the p-value corresponding to the test of association between each of your exposures and all of those DNA methylation sites across the epigenome. It's kind of fun to talk about a Manhattan plot when you're literally in Manhattan. So if you have a good looking Manhattan plot, it looks like Manhattan. You see these skyscraper-like effects emerging from the data. Otherwise, you refer to them as sort of Dutch plots, because if you've been to the Netherlands, you know it's quite flat there. So in this analysis, or in any epigenome-wide association analysis, you're doing a lot of multiple testing. So we penalize ourselves for that. And this horizontal line is thought to be the metric for identifying signals that really rise above. And so what we ended up finding went through our analysis were 46 significant CPG sites that were distributed throughout the epigenome that appeared to show some relationship between adversity and a DNA methylation difference. And when we looked more at this specific set of results, we ended up coding them based on, just organizing them post hoc based on the timing of exposure. And we found that of these 46 CPG sites, more than half were identified by being influenced by exposure to adversity during early childhood, that period from 3 to 5. What was also notable, we had methylation data available at birth, so we could look at, were these differences present at birth? And we didn't find any evidence to suggest that they did. So it suggests that potentially these methylation differences occurred postnatally. And we're now in the process of wrapping up a meta-analysis where we've been looking in other birth cohorts at these relationships. And spoiler alert there, we're continuing to largely find more evidence for sensitive periods than we are for these other kinds of theoretical models. Alex also, because we had these repeated measures data, we were also able to build onto that to look later in development. So we can look at those methylation differences at age 7 and see what happens if we continue out into adolescence and look at 15 to 17. And we also bring in an adolescent time period for exposure. And what we ended up finding there was that for those 46 top loci that I described previously, the magnitude of adversity-associated DNA methylation effects decreased from 7 to 15. In other words, the differences weren't as pronounced, and we wouldn't have been able to identify them had we looked for them again. But the general direction of effect was consistent. But I think what's maybe even more interesting is that we identified 41 new loci at age 15 that we didn't see before at age 7, but speak again to the importance of that early childhood, that preschool period of 3 to 5. So this is a paper we actually just published 2 weeks ago that came out in Lancet Child and Adolescent Health for anyone who might be interested. And now we have an R01 where we're going in a different direction, but really, I think nicely building on this to look at the role of positive life experiences. Like, we all always focus on stuff that's so risky and bad and negative. And so can we start to bring more optimism in a way into our field and look at, like, what does social support do to the epigenome? You know, what does it look like if you have grandparents in your life? Do you see a sort of biology of resilience that starts to emerge? So we have a terrific group of collaborators that I'm working with that I've worked with for many years on this, and really excited to continue to do that work. I also want to say too, you know, maybe I'm starting to convince you that preschool and that time period of 3 to 5 is really important, but I do want to put a note of caution in here, because we've also looked, and I would say I don't think that observational studies have really yet to converge on a single time period of increased sensitivity, at least to child maltreatment. So John Schaefer, who was a postdoc collaborator in my group, now assistant professor at Vanderbilt, he led a systematic review on human observational studies that looked at any aspect of timing in relation to anything that might be related to any psychiatric disorder. So, you know, we looked at psychopathology symptoms, neuroimaging, epigenetic markers, anything kind of related to an RDoC domain. We found 118 unique cross-sectional or observational studies. This is the distribution of the outcomes that were examined. So most of them focused on psychopathology, but you can see, you know, there's lots of other domains here. Maybe not surprising, 75% reported at least one timing effect. When you dig deeper into the literature, though, you don't see a consistent peak period of vulnerability across studies. The biological, quote unquote, domains, or these more objective domains, some people might posit, well, maybe those are where you're more likely to see evidence for sensitive periods, but we did not find that to be the case. So neuroimaging wasn't better able than symptom report to differentiate. Interestingly, nor did study size or feature, which I think speaks to publication bias. Internalizing and externalizing symptoms. So the more inwardly facing psychiatric symptoms like anxiety, depression, for more of those externally facing ones, tended to share more peak periods of vulnerability, but specific maltreatment types didn't. And studies were also almost equally split on whether sex differences were found. The risk of bias was high across studies, largely in not having sufficient statistical power. And one of the big things that I think was really important to note is just the measurement challenges that exist, in addition to other issues that I think we need to really reckon with if we want to drive this work forward. And the topic of measurement is what I want to turn next towards. So if you look at any of the childhood adversity work, you'll see that, you know, our measurement approaches have really serious limitations. So the most common thing that we do is retrospective reporting, like that Ad Health study I mentioned, where you're asking people to retrospectively recall whether they've had an exposure, and if so, how old they were. And as you might imagine, there's lots of issues here. Memory and recall bias. People are potentially reluctant to talk about something with one interviewer, but maybe they will with another. So there's lots of potential issues here. The other alternative is to go the other direction. So do prospective reporting. So in ALSPAC, for example, ask moms if their child was exposed to anything adverse. And that also has issues. So parents might be embarrassed to talk about these painful experiences, especially if they were implicated in the adversity. For adolescents, they might be unaware that their kids were exposed to certain events. And this is why, if you look at the literature, it's no surprise that there's oftentimes low levels of agreement between parents and their kids. The other thing you can also do is look at official records like health and social service records. That's often done in child maltreatment work, but there too, you're getting a fraction of the true cases, as few as sometimes 20% of kids who've been maltreated. So seeing these challenges, I had a very serendipitous conversation with someone years ago who turned me on to the idea of baby teeth. And so the question is, could children's exfoliated teeth or baby teeth serve as novel biomarkers of the occurrence and timing of childhood adversity exposure? So several years ago, we wrote this review article that was published in Biological Psychiatry, where we outlined what we called the teeth conceptual model, teeth encoding experiences to transform health. And what we essentially said is that, you have a psychosocial stress or some kind of childhood adversity. It disrupts some type of biological process. And that could be an epigenetic process or a shift in, stress response circuitry. It then leaves behind some kind of an imprint. And teeth might be a potential tool to be able to understand disrupted processes as well as markers of that psychosocial stress exposure, and then therefore be able to help identify in a predictive way kids who might be at greater risk for mental health problems. So let me share a little bit more about teeth. They're absolutely fascinating, but just to get us on the same page. So most of us are hopefully born with 20 primary teeth. These start forming prenatally, and then they develop over the first couple of years of life. Those teeth naturally fall out of our mouths. They're the only part of our body that falls out as part of a natural process. And those teeth are then replaced by 32 permanent teeth that start forming postnatally up to about mid-adolescence. So you can see that there's overlap in terms of critical periods for brain development and tooth development. Teeth are interesting in that they record the timing of their incremental growth. So you can see, this is a cartoon schematic of a tooth. So the out widermost part is the enamel, underpinning that is the dentin, and those two are comprised of is the crown. And then you also have the pulp chamber. And there are specific cells that develop enamel. So enamel forming cells are called ameloblasts. And the way that ameloblasts are working is that they're laying down this matrix of enamel in a very circadian-like process. And so as that deposition of enamel or dentin is being laid down, it's leaving behind a record of that formation permanently within the tooth. So this developmental process is permanently recorded in the tooth, similar to the way that rings in a tree mark its age. So if you take a cross section of a tree, you'll see those incremental growth lines. It's very similar with teeth. If you take a cross section of a tooth, you'll also see these incremental growth lines. Teeth also record, this recording of development is found across evolution. So we share similar rings within teeth as other species. And teeth are also unique in that they record insults or disruptions that occur during their development. And they do this on two different time scales. And what's really, I think, novel is that they can tell us not just potentially whether a stressor happened, but specifically when. So on a low resolution time scale, you can see, for example, that you see these white marks or these enamel hypoplasias. So that speaks to maybe something was happening as these particular teeth were forming, given that you see these hypoplasias more concentrated to these two central incisors compared to these other and later forming teeth. But you can then leverage the growth ring-like structure within teeth to get even more granular and look more high resolution. So if you have a cross section of a tooth, you can see, for example, in this cartoon schematic, these are these incremental growth lines. But sometimes you see these lines that are darker and wider. And the idea here is maybe this is an indicator of some kind of stressful life event. So this is why anthropologists refer to these as stress lines. And one of the stress lines that's most commonly found in our teeth is called the neonatal line. And that differentiates our prenatal life from our postnatal life. So one of the things you can do is you can leverage these growth ring-like structures to essentially count lines before and after the neonatal line that allows you to date whether a stressor occurred prenatally or postnatally. And most of the work that's been done so far on teeth and how they record stressors has really been more around the physiological stressors, looking at disease, malnutrition, the process of our birth as it gets recorded in the neonatal line, archaeological populations, or what archaeologists call modern, but that's even still very long ago relative to what we think of as modern. But there's really not that much that's been done in the space of psychosocial stress, particularly in terms of tooth formation. But primate studies have suggested that teeth might record psychosocial stress. So Simona Lemmers is a postdoc in my group. She's a biological anthropologist by training. She's led some work, for example, in mandrills, showing that when moms return to mating during the weaning process, or they witness their mother be captured, you can see a stress line that occurs within a week of that particular stressful life event. Not all of the literature is consistent here in this front, but suggests that there could be some interesting possibilities. So hopefully I've sort of built a case for, how is it that we can go from a stressor to something that you then see in teeth? So let's then go from teeth to risk for psychiatric disorders. Most of what's been done in this space is in the environmental health world and looking at toxicants, organic toxicants like pesticides, heavy metals, lead and other metals. And most of this work, though, shows that there are links with a range of different neuropsychiatric disorders, schizophrenia, autism, neuromotor function, and even ALS. So I think, there's really unique and enormous opportunities that teeth may be able to help with in terms of guiding primary prevention efforts for depression and other kind of psychiatric disorders. And so the idea here is, if you hearken back to what I said at the outset of the talk about 10 to 20% of, or 20 to 40% of people will have had their first onset of depression before age 22. And then you marry that with what we know about the timing of tooth formation and the critical periods of those early development that teeth are recording. I think every time when teeth are lost represents a possibility to intervene. So the idea is the first opportunity comes when teeth naturally fall out of their mouths during school age time period. A lot of parents save them. A lot of parents who save them then subsequently throw them away because they feel guilty or what have you. What if we could instead use them to guide primary prevention efforts and do that at a time period where most kids aren't displaying symptoms of psychopathology just yet? Second time comes with orthodontic work. So this is the time where we start to see, adolescents are getting fit for braces. You need to make room sometimes for orthodontic work. Teeth are being extracted. What if we could use those teeth again as an opportunity to intervene and do that at a time where you're seeing increases in risk for depression, particularly in girls, and also increase in other psychiatric disorders? And then the third opportunity comes from wisdom tooth removal surgery. So this is in this transition to adulthood. Kids are leaving home and often going away outside of the home, college and elsewhere for the first time. Huge increase in bipolar disorder, schizophrenia. Here too, when wisdom teeth are removed, let's not get them in landfills. Let's see if they might be able to be used for good. So seeing all this kind of possibility, I decided several years ago that I wanted to become the science tooth fairy and try to pioneer the study of teeth as markers of psychosocial stress. So this is a cover of a children's book that my group wrote. So this is one of the ways that we try to talk with kids and families about, why do we want their teeth? So this has been a great tool for helping on that front. I love puns. So let me tell you what we've been sinking our teeth into in terms of testing this teeth conceptual model. So Simona, the postdoc I mentioned, Mona LaLawyer is also a biological anthropologist, postdoc in my group, and Ryan Lasan, who's a pediatric dental resident, has been really spearheading a lot of this work. One of the first things we did, so in the space of empirical work linking teeth to stress to teeth morphometrics, we published the first evidence to our knowledge that maternal psychopathology and social support was associated with the width of the neonatal line. So we showed that moms who had histories of depression, historically or around the time of giving birth to their children had children who had wider neonatal lines. But if they felt social support, they also had narrower neonatal lines, as we would have hypothesized. We're also now in the process of analyzing data for a study called STRONG, the Stories Teeth Record of Newborn Growth, which is a natural experiment where we've been collecting the teeth from women who were pregnant or raising a newborn during the timing of the Boston Marathon bombing event. So this calendar dated community-wide stressor that we can see, do we see evidence of that showing up perinatally within these teeth? We've also been doing work to try to link teeth morphometrics to health. So we published what we think is the first evidence that enamel volume and thickness correlates with children's psychopathology symptoms. We also have what we think is the first evidence that a biorhythm, or that kind of circadian-like process in terms of those tooth growth structures, also predicts weight gain in adolescents. And then the last area I've also been really trying to push on is around feasibility. So, this is all great and good, but if we don't know what the barriers are to collecting teeth, then this doesn't really matter. So we've also been doing work, both qualitative and quantitative, to try to understand more about attitudes towards donating baby teeth to science. So I'm going to start to transition to the end of my talk and say a little bit more about how I think we can translate some of the scientific knowledge into interventions to promote resilience and reduce health disparities. So we've heard it 1,000 times, that we've been living through unprecedented times. I think the pandemic is still very much with us in the sense that some of us are still masking, but we're really, I think, going to be reeling from this for some period of time. For mental health, this was an area where we had already been starting to see increases in mental health symptoms, particularly in young people. And now people are describing it as this surge following the surge. However, we've also simultaneously been seeing a resurgence in the civil rights movement for racial equality, and starting with that to see institutional and large-scale shifts in the practice of medicine and public health. And where I think we are now is that the stage has been set for us to really catalyze deeper and more meaningful research agendas to identify kids at risk and develop more effective interventions to build resilience and reduce health disparities. And I think there's a couple of specific areas where we can go in that front. So I'll give just 2 examples. So one is, I think we have to do more to identify the buffers or protective factors that can offset risk for poor health outcomes for everyone, and especially for kids who've been exposed to adversity. As I said earlier on, we focus so much on risk and what increases risk, but what also reduces risk for disease. And I think the opportunities for resilience live across multiple levels of the social ecological model, and where we really should be trying to understand within and across levels how this might operate. The other areas, I think we've got to develop and implement tools to measure childhood adversity and differentiate the variation in biological response to adversity. So, anytime you plot data, for example, you'll always see, an increased risk of adversity predicting depressive symptoms, but then you also see these outliers. So this is a person who, had lots of adversity, but doesn't have high depressive symptoms. Why is that? And I think part of the answer might be in trying to differentiate the biological assessments that characterize the exposure from the biological response to that. And that might be some areas where we can start to better tease apart these individual differences. Let me say a little bit too about the clinical applications and implications of work on epigenetics and exfoliated teeth. So being in a hospital setting, it's been striking to me as an epidemiologist in a hospital. I've sometimes had the chance to talk with patients and families. And the things that strike me the most is oftentimes you hear the same thing, kind of 2 key themes emerge. The first is that people want answers. They want to know, why did their loved one develop depression or another mental health issue? The second thing is they want hope. What can be done to prevent these mental health problems from affecting other people I love? And so this is where, what if teeth, when paired with existing tools and insights like family history and genetic and other omic markers, could provide answers to these burning questions? So after they naturally fall out, most children's teeth are stored or thrown away. What if these hidden in plain sight objects could be used instead to give patients new insights and help scientists identify targeted strategies to promote resilience among kids exposed to adversity? So maybe we might be able to one day add methylation data and exfoliated teeth as a screening tool to identify kids at risk for mental health problems and use those insights to connect kids to interventions years before the onset of psychopathology symptoms. So, imagine a world, for example, where a child loses a tooth, whether that's because it naturally falls out or is removed to make room for orthodonture or get rid of those wisdom teeth. And imagine if that tooth is then shared with a practitioner, a dentist, a pediatrician, or another provider. And that provider sends the tooth to a specialized lab who knows how to extract data from it. And that data is then interpreted by a psychiatrist or another mental health provider who collects data on other omic markers and survey data and history, family history data. And ultimately, you're able to marry all of this data to identify people at highest risk and connect them with preventative interventions. Not just biological, but what about exercise or social support or other things of this sort? It could also potentially include biological treatments, though, that maybe are reversing these harmful methylation shifts. And so this is where, I'm envisioning a kind of marriage of dental and mental, and where that might ultimately lead us towards both precision medicine, where we can do, identify strategies to implement the right treatment at the right time for every person, but also precision public health. How do we do this at a population level? So with that, I'll just end by one more point, which is, hopefully you've gotten a sense of how deleterious childhood adversity is. I do want to also say, though, that I think most of us might feel inclined to want to go out and start trying to, if you're a clinician, screen for it or actively do something. But I want to give some caution here. I think there really are some real world caveats that people need to be thoughtful of. So we summarize some of these in a comment we wrote for Lancet Child and Adolescent Health at the end of last year. So I'd encourage you to take a peek at that if you're interested. And with that, thank my current and past collaborators and say that science has really been such a fun global enterprise. And thank my lab members, sources of funding, and I'm happy to take any and all questions you have. Thank you so much.
Thank you. Thanks so much, Erin. That was so fascinating and great to see how your work has evolved. I have a question that I'm sure you get all the time, and so I just wanted to know your thoughts on it, which, you started the presentation with, child adversity. If it's causal, we can prevent 30% of psychiatric disorders. And a lot of the childhood adversities in the beginning of your talk were around child poverty. And so how scalable, if we analyzed all these baby teeth, we're sending them to be analyzed in microscopes, that's going to cost millions of dollars to do. If we know childhood poverty is the causal factor, why don't we intervene there?
I think that, I think as public health practitioners going through a pandemic, we realized even more the political challenges of doing our work. And I think there is still out there people, particularly in positions of power, policymakers, who say their kids, they're going to forget this stuff. This is fine. I went through this and I turned out to be fine. So to me, the power of the biomarker or, these kinds of tools is that it can objectively show that people can carry with them the imprints of things that happen to them very early on, and that can have lifelong consequences for their health. I also think that, I'm not someone who focuses on a particular adversity. I feel like there's so many different adversities that really matter for different things. And I think the policy space is really complicated around child poverty. It's interesting. We published a paper looking at mobility patterns for epigenetic signatures. So imagine what I presented on here, but also adding in mobility. So, and looking just at financial related markers. So we looked at, income and other markers of socioeconomic status. So for example, if a family had lost a job, gained a job, so these fluctuations in income. And we found that most of the data were consistent with these mobility models. And we had a beautiful what I thought, humbly, was a beautiful paragraph in the discussion section, totally targeted towards policymakers, that reviewer said, you're over speaking and like, kick this out. So I just share that because I think there is this little bit of this tension, right? Where all of our work is trying to speak towards that, but there are constraints sometimes on what we can say and the political realities of where we live in. And I don't have all of the answers, but I'm excited to have the conversations with people to be able to help figure that out and how we can collectively roll up our sleeves to try to do something around that.
Yeah, yes, of course.
Sorry, that was Carrie.
Someone identified.
My name is Jen Dykeshorn. I am visiting, working with Carrie, but I'm on faculty at University College London in the UK. Really fascinating talk. I did not realize how strange and interesting teeth were. So that was really, really interesting. My question is somewhat related, and especially thinking of what you were presenting about enamel volume and thickness as a predictor. I was also wondering if like access to preventative dentistry affects that, because I would see that as like very important, as children who would have access to preventive dentistry might have better enamel, and that would be like socially and financially patterned.
Totally. And I think part of the challenge for this work and how it evolves over time is, first of all, differentiating what's localized to the mouth and what's systemic, and how can you best characterize adversity as it appears in the tooth, even among the most highly exposed, even among kids who are very highly exposed to adversity and who may have lower access, and where you're just seeing these abnormalities show up in their teeth. And I can give you an example of that. So we have data, we have teeth that we've gotten from a cohort in South Africa, the Drakenstein cohort study. And the folks, when we got them in the teeth, they said, wow, these look just at the face in the envelopes in the bag, look so different from the teeth we're getting from the Boston Marathon bombing study. Part of that might be reflective of, environmental adversities that are important. Part of it might be reflecting oral health, markers. So part of it is, I think, trying to disentangle that. The other thing too, though, is that you can also not just look at enamel. So for example, if you have a really carious tooth, a tooth that's, coated in decay, you might still be able to get signal from dentin or from, like measuring aspects of the pulp compartment that still could be influential. So I think this is an area we've been trying to figure out. How do we both study kids who have these big histories of adversity, but also do it in a way that we will have something interesting to be able to measure?
Yeah, and I suppose that also having it connected to some of the existing cohort studies would be really powerful in that way.
Exactly.
You're able to understand some of the other important confounders. Thanks again.
Yeah,
that was really,
exactly.
really interesting.
Thank you.
There might be some on the chat.
Yeah.
I have a question, actually. It's not a few seconds short, but I have another question.
So I was listening to this true crime podcast, and they identified.
Wait, can you clarify the true crime?
I don't remember, but I thought of your work. I mean, I was like, oh my God, this is what Erin does, because they had taken the teeth of the person who died and they figured out where, like, they're like, oh, they spent their adolescence in a high plain region, and then they moved to a more coastal region when they were like 18 years old or something like that. And it was so like, they're doing that forensically now. Yeah. And so it made me think, are there ways to extend your work to also study kind of place-based spatial epidemiology of mental health?
So there are people who are doing it for repatriation efforts for military members who've died overseas and they can't identify who they are, but have the dental record. So essentially you're leveraging like chemical isotopes and the fact that the chemical composition of the water in New England is different from here, and you can piece all of this together in a tool that that outlives or stands other things. So yeah, there's so much to do here in this space.
Does anyone else have a question? I have one question. So this is Charlie Brannis. We have a couple of studies with teams here in Mailman and Teachers College that are looking at adverse childhood experiences. And this has been really fascinating, very educational for me. And you took my question away because I was going to ask about PCEs, positive childhood experiences. And we have a couple new proposals going in on PCEs right now in children. And one of the questions that keeps coming up is this question, I think it's coming from economists actually, about symmetry. And that is, if we focus, I think the basic question is, if we focus on preventing adverse childhood experiences, do we receive the same return if we then also focused on sort of the other side of the coin, enhancing positive childhood experiences? Is there that symmetry in intervention or policy?
Yeah, so. and also it's an artificial distinction, right? Because these things don't live in isolation. We try to study them in isolation as best we can, but they don't. I think that's left to be determined, right? And hopefully our methylation work will help to do that. It's interesting. The resilience literature is also really complicated around how you can measure these events. So we got pushback from reviewers, for example, where we use the language of protective. And so while the idea of protective is that it's protective, it's a positive life experience that protects in the face of risk. So then these PCEs are really more promotive factors, so that are happening independent potentially of risk. So then the modeling strategy that sort of gets applied to that becomes, I think, a little bit challenging. But in our work, we're going to try to look at these promotive factors on their own and in the context of different adversities. And we'll hopefully be able to get some sense of what that potential symmetry could look like. But I think, to kind of come full circle, it's really hard because, like you said, Carrie, about poverty, that's a really big underpinning. It's almost like a latent variable in a way that underpins so many of these other adversities. Maybe there are positive life experiences that are similar to that, and where that kind of toxic stress model of saying having a loving and caregiving one adult can really be that, influential factor. Maybe there are those kinds of things, but I'm not quite sure. I think also partly where we're fighting as a field is what counts as an ACE. And then we're going to have the same parallel discussion around what counts as a positive life experience. So.
That's a great comment. Exactly. Okay. I want to thank, is there another question?
Yeah. Just as a great talk, Erin, you've gone so far with this. I was wondering, well, I just want to quickly say, I think the need for objective measures is just fundamental. And the ACE measures just aren't good enough, really, for this kind of thing. And so this is eventually going to change the whole approach, I think, to this field. But I had a question about, have you been able to, early on we tried to distinguish these different models of life course experiences, which you explained. Is that how applicable is that to studies using, T? Can you do it? Like what kind of spacing did you, and that kind of thing?
Yeah, I think it is because, so for example, well, first of all, there's multiple measures that you can derive from teeth. So the growth ring-like structure is just one example, but it's maybe the most elegant example of where you can really differentiate these different life course models. So for example, you can within a tooth count the number of stress lines that exist, and that could be a marker of accumulation. You could also look at the occurrence of those stress lines perinatally that occur, postnatally, So that might be an indicator of recency. And then because you can leverage the position of the neonatal line as essentially the darkest incremental growth line or stress line in teeth, you can count lines backwards and forwards. So you can start to calendar date essentially down to the level of a week when a particular exposure occurred. So that's where I really see there being enormous potential for getting much more granular around potential sensitive period questions, and where we don't have to then rely on age reporting anymore, but we can really focus on specific time periods in someone's development, and also acknowledge that people grow at different paces. And so using the sort of circadian-like rhythms within the tooth to also understand who might be a faster grower or a slower grower. And that's where I think it really does open up a whole set of possibilities that our kind of age at markers in the sensitive period space just aren't sensitive enough to be able to allow us to do.
That's great. And can you use Andrew Smith's and similar models for that purpose too?
Probably. We haven't done it yet. The challenge with teeth is that it's small data. So it's, sample sizes of, so our strong study, the Boston Marathon bombing study, we have teeth from 280 kids. So I think those, we haven't tried to use those methods yet for that, but I think possibly.
Thank you for a very stimulating talk. I admire your courage because this is an enormous challenge with a lot of noise everywhere. Let me do two observations together. People are not reliable observers of past events. Mm-hmm. I'm thinking of Harvard longitudinal studies where people were interviewed at maybe 10-year intervals between the ages of 18, college kids, and age of 50 or 60.
Yeah.
And then the recall at age 60 about these various time points is compared to what they wrote down at the time. So there's a big difference there. But it has some longitudinal recording of financial events, about family events and various other things. So I was wondering, could you marry a data set of this nature with an outcome measure that you are now proposing in the form of teeth?
You could.
Like you have a longitudinal study that looks out. It's a different example, an interview done at age 18, and then dementia by way of brain, not biopsy, but post-mortem, where you have an exposure and an outcome.
Yeah, well, the other thing too is also as people age, they lose teeth. So you can have access to permanent teeth in older adults that you could potentially study.
But only if you can persuade the people who are part of that study to turn over their teeth as they are shedding, or to allow a teeth to be pulled after they're dead.
Yeah, I think so our Boston Marathon bombing study is pretty self-selected. I think we couldn't have imagined a harder group to try to recruit starting in December of 2019. So the folks who are part of that study are, much more privileged than the average population. I think that parents are, what we found, and we have a paper that we was just invited for a revise and resubmit. The children's book that we wrote helps to shift people's attitudes towards donation. So even among people who said they were already willing to donate teeth, hearing more about why we're collecting them, what we do with them, how we keep them secure, that we're trying to do this in order to understand ways of promoting healthy child development, people can be even more motivated. And I think that the challenge in the US is that, particularly for firstborn kids, moms in particular feel sentimental about saving teeth. Ideally, you'd want to be able to have as many teeth from the same child as possible, but it could also be that having one tooth is informative. So that's, to me, where I feel that there's I feel optimistic about it not being a problem to try to get teeth from kids and families growing up.
But is the analysis of teeth destructive, or couldn't you return a whole teeth after you examine?
So it depends on the analysis that you do. So if, for example, you had a population that was really wanted to have teeth returned, you could do micro CT, which is completely non-destructive. You could also do with the histology, the incremental growth mark work that I described, that you do on half of a tooth. So you save the other half, we save it and we're not returning it. We've had a few families in our study who don't donate because their kids want to save the teeth. But for the most part, they're happy knowing that if they did want it back, they could get that other half.
That's great. And I think we're over time and when we've kept you. So thanks for a stimulating talk. We see a lot of good questions. Are there any more questions? Perhaps Dr. Dunn can stay a little bit longer. Thanks, everybody.
Thank you. Thank you.